Hello, everyone, and welcome to the webinar, The Social Organization of Perinatal Care for Mothers Living with HIV in Canada, Revealing Promising Practices. My name is Rachel McLean, and I work with the Canadian Public Health Association, and I'll be your host today. Before I hand it over to our presenter, Alison Ion, I just have a few housekeeping items to go over. So this webinar is being offered by the Canadian Public Health Association as part of our webinar series that we'll be hosting over the next several months, focused on the reduction of stigma associated with sexually transmitted and bloodborne infections. More information on this webinar series can be found on CPHA's website at the link provided on your screen. And you can also connect with me if you'd like further information on the webinar series. I'll provide my email address at the end of the webinar today. So hopefully you can all hear me already. So as it says on the screen, you can listen in using a headset or a USB speaker connected to your computer, or you can use the speakers on your computer. And due to the larger number of participants that we'll have on the line today, we've disabled everyone's microphone. We will have some time at the end of the session for questions. We just simply ask that you use the chat box to the right of your screen to pose your questions to our presenter today. And then lastly, before we begin, just a quick note to say that the webinar is being recorded today, and it will be made available along with the slides on CPHA's YouTube channel in the coming weeks. And if you have any questions in terms of if you're having any technical difficulties throughout the session, again, I would encourage you to use the group discussion. I'll be monitoring the chat box, and I'll definitely connect with you if you're having any issues. So today we are going to hear from Alison Ion. I'm going to provide you with a brief bio for her, and then I will hand it over to Alison. So Alison Ion is a PhD candidate in social work at McMaster University. She has worked and volunteered in the HIV sector since 2001, contributing to community development, education, and research initiatives, including community-based HIV research in the areas of women, peer support, and mothering. Alison's doctoral research uses institutional ethnography to investigate the health services that women living with HIV utilize during pregnancy, childbirth, and early postpartum. Alison is extremely grateful to be funded through a Vanier Canada graduate scholarship to engage in this work. So with that, I will hand it over to you, Alison.
Thank you very much, Rachel. So as Rachel mentioned, I'm a PhD student in the School of Social Work at McMaster, and over the last 8 years or so, I've had the opportunity to contribute to research focused on the experiences and needs of mothers living with HIV in Ontario, as well as more broadly across Canada. And specifically through the program of community-based research led by Dr. Sarah Green at McMaster, and in particular, the HIV mothering study that was funded by the Ontario HIV Treatment Network. I've learned about kind of the myriad of perinatal experiences that women have that can be challenging, where they can feel that they've been othered in some way, and that really supports this idea that women living with HIV have a unique experience of pregnancy, childbirth, and motherhood because of their HIV status and because of the clinical procedures and recommendations that they're expected to follow. So for my doctoral research, I was interested to take a closer look at how and why these experiences come to be. Was there something about how healthcare institutions are organized that was creating the conditions in which women could have these stigmatizing and negative experiences? Was there something about the routine institutional processes and work practices of people operating in clinical settings that was actually creating these conditions? So what I hope to share with you today is some of the things that I've learned through this journey, and hopefully impart some ideas about how to critically reflect upon our practices, our policies, and the regulatory structures that we all find ourselves in, and hopefully start a conversation that relates to the practice and work that you're all doing. So this is basically the objectives of the webinar, and kind of ties in with what I just said. And how we're going to do that is we're going to review some of the practices and guidelines pertaining to perinatal care for women living with HIV. I'm going to present two vignettes, and these are real life scenarios, as a way to highlight some of the promising practices when delivering care and support to mothers living with HIV. We're going to end with a Q&A, and I really do want to make this, as interactive as possible. I know it can be challenging sometimes with web-based platforms, but I have built in places where you'll be able to answer some questions, and provide feedback and really get involved in the conversation. So before we jump in, I'm really interested to know who is here for this webinar. So you'll see a poll function on the right side of your screen. Rachel just put it right in the middle of the slide. Um, so I'm wondering if you could use this poll function to answer this question of what discipline or perspective you identify with. Um, and I realize that you may identify with more than one category, if you can't choose more than one, but this is really just meant to give a snapshot of who is here today, in this webinar. So I'll just give you another few seconds to fill that out. All right. I think that's probably about great. So we'll end the poll. So it looks like, I can't really, there we go. Sorry, thank you. It looks like we have quite a few nurses in the room, some healthcare administrators and policymakers, and other identities not listed here, and then some other groups as well. So that's wonderful. I just wanted to get an idea of who was joining us here today. So thank you very much for doing that. So we're going to move along then. All right. So women have accounted for about 25% of people living with HIV in Canada over the last decade or so, and this amounts to about 17,000 women, a large proportion of whom live in Ontario. And since the start of the HIV epidemic, we have seen tremendous advances in treatment options. So this has meant that for many people, HIV has evolved into a complex chronic illness that can be managed with medication. And this also means that HIV has now been deemed a disability under the law, and people living with HIV are eligible for receiving social assistance. So given this evolution of HIV and expanding treatment options, parenting is a growing reality for women. And nowadays, we see over 200 infants born to women living with HIV in Canada each year, and the majority of these infants reside in Ontario. A survey that was done some time ago by Dr. Mona Lutfi and colleagues also found that a large number of women living with HIV in Ontario desired to have a baby and intended to give birth in the future. So, when we're thinking about pregnancy planning, maternity care, and parenting in the context of HIV, it's really something that cross-cuts a number of health and social service sectors. So we really have to think about this, in terms of all sorts of health disciplines and spaces where people might be accessing care. So these medical advances also means that the likelihood of HIV transmission during pregnancy, childbirth, and postpartum has significantly decreased. It used to be about 1 in 4 children were born with HIV, and nowadays in many jurisdictions there are no HIV transmissions. And we've seen since the late 1990s very few infants, about 1 or 2 per year, were born in Canada to women living with HIV who did not receive HIV care during their pregnancy. So with HIV treatment, and if a woman's viral load is fully suppressed, the chance of transmission can be very low and less than 1%. So you might be wondering, how does this happen? And women typically have a lot of interaction with the healthcare system during their pregnancy. They're closely monitored by their obstetrician, their HIV specialist, and sometimes they receive support from other community and social services. And so, although women living with HIV receive the same type and amount of routine prenatal care that all women, all pregnant women could expect, their pregnancies are categorized as high risk. And so they are referred to a specialist clinic for specialist care. And this specialist care is typically located in regional teaching hospitals where they're going to be interacting with large multidisciplinary teams that includes residents and other learners. They will see their maternity care providers in addition to their HIV specialist and other healthcare providers that they may be seeing on an ongoing basis. And women are typically already aware of their HIV positive status and on treatment when their pregnancy is confirmed. And if this is not the case, then testing is done early so that treatment can be initiated. Nowadays, women are also now recommended to have vaginal deliveries, provided that their viral load is below a certain level. Otherwise, a C-section might be recommended. The mother receives medication during childbirth, and baby receives medication postpartum. And the current recommendation around infant feeding is to formula feed their babies. The baby is followed for serial HIV testing and is seen typically by a pediatric HIV specialist for checkups. And there may be some variation depending on the region where you're located, but these are, for the most part, the recommended guidelines and practices during that perinatal period. You might be thinking, wow, there's a lot going on here. And so, although, this is a really exciting time for women, welcoming a new baby, it can be a stressful and very intense time for women. Women living with HIV are already used to interacting with the healthcare system as they go about getting their HIV care. But pregnancy and childbirth can add another layer of complexity. It's another clinic they have to visit, it's another healthcare team they have to interact with. And as you see from these guidelines, there's a lot happening, there's a lot of things that they're having to do. So I'd like to pause at this point in the presentation. Um, I'm interested to know if this is a review for you or if you're hearing this for the first time. So, choose yes if you're already knowledgeable about these guidelines, or choose no if this is the first time that you're hearing about them. And I'll just give you another few seconds to complete that. Okay, so we're kind of split, but this is good to know just in terms of how much you already know and how much this is new information that you're hearing for the first time. So that's great. Thank you very much. So I think it's also really important to say, and this is something that has come up in previous work that I've been a part of, time and time again in other research on HIV and motherhood, that women living with HIV are navigating pregnancy care in a context where there are pressures and expectations about what it means to be a good mother. And for some women living with HIV in this context of healthcare and pregnancy monitoring, they find themselves having to defend their reproductive rights. For some women, negative care experiences actually begin with questions or remarks about the fact that they're pregnant in the first place. And these questions are often grounded in assumptions or maybe, coming from a place of incorrect knowledge about HIV transmission and, the current realities of living with HIV in Canada today. So you'll see, a quote from Adrienne Rich and a quote from Sarah Reddick about the gaze that all mothers are under. And then the final quote from the mother living with HIV who's saying, I have to defend my right to have children, you know, from the get-go. So at this point, I'd also like to pause and point out some of the language that I've been using so far. And I found in the work that I've been a part of that reflecting on our language and the language we use kind of day to day can be a very powerful way to understand how our routinized practices may be experienced negatively or even in a stigmatizing way. And this slide outlines some of the terms that came up during the HIV mothering study. That our team, which included mothers living with HIV who were leading the research, who they felt these terms could be clarified and alternatives could be provided. So, for example, you might have noticed I've been referring to women living with HIV throughout this presentation. And perinatal transmission is most often used to refer to HIV transmission that occurs during pregnancy, childbirth, and early postpartum. So this just gives you a snapshot of, again, some of the language that members of our team have recommended. Also, so far in this presentation, we've been able to debunk some very common assumptions that are out there about HIV. And as I said earlier on, HIV can be effectively managed with treatment. And for some people, treatment can be very difficult, and this isn't kind of a across the board statement, but nowadays HIV is viewed as a complex chronic illness. And we see rates of perinatal transmission being very, very low when antiretroviral therapy is used, to rates less than 1%. So those are some common things that I've heard in the work that I've been a part of that can be misunderstood or not known at all. So as I mentioned at the beginning, through the HIV mothering study, we learned about women's care experiences during pregnancy, childbirth, and early postpartum. We heard about women's positive care experiences when the lines of communication were open with their healthcare providers, when they felt taken care of and listened to by their healthcare team, and when care was accessible either because of where it was located or what appointment times were available or just the general approach that their providers were taking. We also heard about negative care experiences when communication was poor or absent, or when women felt silenced and that they didn't feel like they were an equal player in their care, when they felt discriminated against because of their HIV status, or when their concerns about privacy and confidentiality were not taken seriously and their HIV status was disclosed to people that they didn't want to find out. So we really see these experiences on a continuum. And I was responsible for coordinating the HIV mothering study, and I was based in an HIV clinic within an academic teaching hospital. And when I met with women involved in the study, I heard about their realities, all the things that they do to attend their appointments, how they juggle work, school, parenting, how they're preparing for their baby, etc. But I also became aware of the standpoint of healthcare providers who, were basically implementing clinical practice guidelines and whose practices were based on a particular outcome or goal. And sometimes these goals might have been different from the women receiving care, but it was always coming from a place of, a guideline they were following or basically the directives of their work. So I came to see that there was this disjuncture between the standpoint of women and the standpoint of people operating in healthcare in terms of how they may experience and perceive services and the therapeutic relationship. And witnessing this also made me wonder about the routine practices and encounters in healthcare that can sometimes be experienced as stigmatizing and challenging. What might be going on here is there's something about how healthcare is organized that can help to illuminate possible ways to optimize care delivery and the experiences that people are having. So, for my doctoral research, I conducted an institutional ethnographic inquiry, and I was trying to connect the dots between the experiences of women living with HIV, the doings of people in the institution, so it might be nurses or physicians, and how their actions are being coordinated. And I really wanted to investigate the conditions or ruling relations or the regulatory frames that we all find ourselves in that were, contributing to women's experiences and actually producing the conditions of women's experiences. So this brings us to our first case scenario. And it's based on the experience of a woman who participated in my doctoral research. So the frequency of her prenatal visits were increasing as her pregnancy progressed. And she understood this, but she was frustrated because there was quite a bit of rigidity with the appointment schedule, along with a lack of clarity she perceived from her healthcare team as to why she had to attend a specific clinic for procedures that she thought she could get in her community. So, for example, an ultrasound. So she said to me, a nurse called me a few times and said, "You've got to come in. We haven't seen you in a month. And the prenatal clinic wants me to be here every 4 weeks at least." They never gave me an explanation. "Because you're HIV positive. You have to come here. We need to see you." I have little kids at home and I'm a single mom. I don't drive. It's an hour drive to get there and a lot of finagling. It's a long day to bring young children for 5 hours. Cab rides there and back, food, diapers, all this stuff you have to bring. I asked this woman what she thought about the nurse that she was speaking to on the phone insisting that she comply with the appointment schedule. And she responded, "My assumption and how I felt she was talking to me was, you're HIV positive, you're irresponsible, you're an ex-drug addict, you're not taking care." It was like she was looking for something wrong because I'm HIV. This is my third pregnancy as a woman living with HIV. I'm their lowest high-risk patient. I'm on my meds, I don't use drugs and alcohol, I'm perfectly healthy. I'm not doing anything that would put my baby at risk. So this woman really experienced these phone calls asking her to attend her appointments as othering and really related to her HIV positive status. And she had a really negative, experience of these things. So then I met with healthcare providers and I was interested to understand the rationale to increase prenatal visits over time. And I learned that the reason for prenatal visits increasing over time was grounded on the assumption that all pregnant bodies, regardless of HIV status, should be monitored to respond to any emerging complication. And really, it's to ensure minimal risk to the baby. So one obstetrician told me, "We start escalating visits towards the end of pregnancy. On a week-to-week basis, there's a higher and higher probability of something being different. The fluid starting to decrease because the placenta doesn't work as well, the blood pressure starts to go up, or some other complication that happens." And another nurse highlighted the importance of all women attending prenatal appointments in the high-risk clinic to ensure a healthy pregnancy. And it also would mean that women would have options in the event of a complication emerging. She said, "There are different things that happen at different times in pregnancy. If we miss that boat and they say, 'Well, I can't come,' then at 24 weeks, they have anatomy, ultrasound, baby has a big bad heart. We're no longer in that window of time for a termination, if that is what they wanted. There's risks to everything, right? Pregnancy is a time-limited event, and we don't see them for the first 3 months until 12 weeks. So we only have that 6 months of time to care for them and potentially impact or make sure that, the pregnancy is as healthy as possible." So I thought this was really interesting. The goal of attending appointments from the standpoint of healthcare providers is to be preventative as it relates to potential pregnancy complications. And of course, the women that I talked to want this goal, have this goal as well, and they want to ensure a healthy pregnancy. But it became clear when learning about healthcare providers' work that the availability and scheduling of appointments was influenced by hospital logistics and prenatal care standards that suggest a certain frequency of visits. And when combined, these factors really create particular conditions that pregnant women are expected to comply with, even if their social circumstances make it difficult to do so. And healthcare providers really recognized the difficulty that some women have when attending their appointments and admitted that the system was not always flexible to correspond with women's realities. And this is because of the way the system is organized in terms of, when appointments are available and being really rigid and rigidly tied to care standards. So I think it's important to acknowledge that there may be institutional factors where you work that are creating some rigidity or an inability to be flexible. And actually, on the receiving end, the person that's receiving the care could experience this in a really particular sort of way. In this case, the woman thought that she was being, discriminated against. So how these things and these standards and these expectations, or kind of what clinically might be expected of a woman or recommended, how this is communicated to women really matters. What are the expectations on the part of the healthcare team? And what information is this based on? Is it based on research evidence? Is it because it's the way that things have always been done? And I learned from another obstetrician that interestingly, the time at which certain ultrasounds were ordered really was kind of like, well, we just do it that way. And it wasn't based on, like a systematic review or kind of research evidence. It was just, we think we should do it at this time. But there could be a window of flexibility if women can't, for example, make it in at that exact, 24 weeks or whatever. So it was really interesting. So I just want to take this go a little bit deeper and say that, monitoring women's bodies to ensure that that the healthcare team could be responsive to any presenting complication was a practice that all healthcare providers that I spoke with referenced. But some providers stated that if women were not able to comply with the schedule that they set out, that this could become a proxy measure for their ability to parent. So, for example, if women became non-compliant with their prenatal appointments, some providers questioned their capacity to look after their children. As one obstetrician said, we understand when the patients say, I lost my keys, and they miss a couple of appointments. We don't harass them with, social work is going to be seeing you. Other patients, however, who are less compliant with visits, sometimes you do actually have a concern about, are they actually taking their medications regularly? Do they actually have the stuff at home to look after themselves and this baby? Because they don't seem to be able to have the means to come to appointments that they need to come to. Are they going to be able to, do the care for the baby after the delivery that needs to happen too? And I think this account, it's a really important explanation as to why people working in clinical settings might be persistent about women attending their prenatal appointments. Not only is it to ensure that women are following certain prenatal recommendations, but appointment compliance could become evidence or be used as evidence for women's parenting capacity. You know, and the extent to which it may be perceived that they pose a risk to their baby. And if women fall short of these institutional expectations, the need to attend appointments can sometimes be amplified by their healthcare team. But I think it's really important to point out that women's abilities to participate in prenatal care as it's currently organized may vary depending on their social positioning, their past experiences, including the distance they live from the hospital and even how they get to the hospital. And it's important to question our assumptions that we might be making when drawing a relationship between attending appointments and a woman's parenting capacity. Um, you know, is that a direct line? I don't think so. And just pause and take some time to reflect upon our own assumptions or biases that might be creeping in. And also, just a note here, I've been using the term compliance because it was the institutional language that I heard. But I think that that term can have some negative and paternalistic connotations. And certainly, there is a sociological literature about compliance and adherence that is interesting. So I'm not endorsing that language, but I just wanted to acknowledge it as institutional language that I certainly heard. So now it's your turn. And I'm wondering if we can use the chat function to share some wisdom about this scenario that I've just walked you through. So I'm looking for kind of, 2 to 3 word answers, so we can review it rather quickly. Um, so the first question is, I'm just going to go through all questions and you can share some of your thoughts. Why might the woman that whose quotes I shared here attribute the pressure that she feels to attend her prenatal appointments with her HIV positive status? What biases or assumptions might underpin the opinions and subsequent actions of the healthcare providers working in the hospital? And could the situation have been handled differently? What might you do or say in this scenario? So if you want to take a moment to, you know, give some feedback, jot down your thoughts. So I see that Renee wrote stigma is experienced in so many aspects of life. Previous negative experiences in the health system by Carly. Past stigma, fear of judgment. And stigma that an HIV positive woman is having a child. Lack of updated knowledge about among healthcare providers when it comes to supporting a person living with HIV. Yeah, it's interesting. I think, previous experiences definitely shapes, how women might go into future encounters for sure. Providers are mistaking women's struggles with the social determinants of health for a lack of care for her pregnancy and future child from Angela, and blaming that the HIV condition is mom's fault, either unprotected sex or drug use. Yeah, and it's interesting how, our assumptions and biases can creep in, sometimes subconsciously without us even really realizing it. And Carly said a lack of understanding or knowledge of pregnancy, childbirth with HIV. Yeah. So Katie says, this idea of, well, she should know why she needs to come to appointments and potentially not communicating effectively as to the importance and reasoning of the appointments. That's something that I absolutely heard, where there was a disconnect between, what women, like women understood that going to appointments was important, but they didn't understand maybe the rigidity of it, or why, certain appointments had ultrasounds and certain ones did not, certain tests or certain procedures, at certain times throughout the pregnancy. Like there was still some misunderstanding about that. Even this idea as to why they had to come to that, drive an hour just to have an ultrasound. There was a clinical reason for that, in terms of the ultrasound being calibrated and relying on that diagnostic test as, the machine that they always use, and not, and trusting its results. So, but then it means that the woman has to travel, quite a distance just for that ultrasound. And these things are not always communicated. So we have some suggestions here about what we can be doing instead. So we have, need to have a conversation with the client about what would make it easier for her, providing more client-centered care. making sure that there's an explanation of the need for increasing appointment frequency and that everyone follows the same schedule. What could we do to help you attend appointments? And absolutely, the healthcare providers that I met with, they were trying, but it was difficult to implement these things within a large institution and a really busy clinic. But yes, carving out that time and kind of building in mechanisms to make things more accessible for women is a great idea. These are all really great ideas, and I appreciate everybody offering these really great suggestions. I think this idea of being clear about the reason for prenatal care intervals um, and more collaboration is really important. Great. Okay, I'd like to move us along. And I'm going to walk you through a second case scenario. So, a few years ago, I met with an HIV mothering study participant for her postpartum visit. And at this meeting, she was telling me about her childbirth experience. And because of the timing of going into labor and not being able to make the distant trip from her home community to the hospital where she had planned to deliver, she ended up having her baby in a community hospital where deliveries of women living with HIV were pretty rare. So she recounted her interactions with a provider in the labor and delivery unit and said, the doctor came in, turned around, looked at me, said that we're not equipped for AIDS. I've never seen this doctor a day in my life, and I started to cry. I yelled out that he had bad bedside manner. This is a hospital. This is the place to feel safe, not discriminated. Because of the stress of that, the baby ended up not moving, and the contractions went away. He looked at me and he says, I don't even want to hear how you got HIV. He came back into the room. He had a shield on. He had gloves right up to his shoulders. He was totally covered. I mean, was this guy going deep sea fishing or was he preparing for a baby? And it's not like he's going to get HIV from me. I'm undetected. And I have to say, although this is specific to childbirth, I have heard other experiences where people living with HIV have felt stigmatized or othered or kind of feeling infectious because of the protective equipment that is worn in different healthcare contexts. Even, the act of wearing double gloves when going for blood work is something that I've heard quite commonly. And this woman was very emotional when I met with her, and I left that meeting, with tons of questions. What did this healthcare provider mean when he said we're not equipped for AIDS? Was he referring to medical interventions or treatments to prevent transmission during labor? Or was he referring to certain infection control practices that were supposed to be employed when a woman living with HIV was giving birth, but that this hospital didn't, like, they weren't equipped to enact? And this woman had such a visceral reaction to his shield, gloves, and other protective equipment. And I was wondering, was this a result of his rude demeanor and stigmatizing comments about how she had acquired HIV, or was there something else going on here? Was the protective equipment that he was wearing over the top and completely unnecessary? And I had more answers than questions. So years later, in my doctoral research, the use of personal protective equipment emerged, or PPE, you might know it as well, emerged as an important issue in the work of healthcare providers looking after women living with HIV, in particular at the time of childbirth. And importantly, I learned that serological test results that categorize women as positive for HIV and hepatitis infection activate hospital staff to don certain PPE at the time of delivery. And it also came to light that the use of PPE was not universally applied to all women during childbirth, regardless of their serological status. So one nurse explained to me, if I'm going to take a mouthful of somebody who had hepatitis or HIV, that theoretically has an impact on my personal health. So then I think that PPE, the ante is upped. Should they wear a face mask for every single delivery? Theoretically, yes. I can tell you they don't always, unless it's an HIV or hepatitis positive patient. We have the luxury of knowing the status on all our patients. For people who have been in healthcare or nursing a lot longer, there's still that little bit of fear that never went away. I think maybe the information we have about people's status is almost a detriment to us, that we don't protect ourselves with every single patient the way we probably should. I really appreciated this nurse's explanation about how serological test results set in motion activities related to PPE and how a positive HIV or hepatitis status increased the delivery unit staff's vigilance at using PPE. And I assumed that communicable diseases like HIV and hepatitis were some of the parameters upon which PPE would be recommended. And I then, sought to understand the regulatory documents that guide these practices. So I turned to the Guideline for Infection Prevention and Control in Perinatology, and this outlines parameters for the appropriate use of PPE in labor and delivery. And this guideline revealed that the use of PPE is contingent on the nature of fluids present during childbirth and not on the woman's HIV or hepatitis serological status. So the guideline says both, a gown and mask and eye protection are used to protect the mucous membranes of the. A gown is worn when a procedure or care activity is likely to generate splashes or sprays of blood, bodily fluids, etc. And a mask and eye protection are used to protect the mucous membranes of the eyes, nose, and mouth when, same thing, generating splashes or sprays of blood, bodily fluids, etc. So the guideline itself does not explicitly mention HIV infection, and the fluids would be expected in all deliveries, not only those of women living with HIV. And as the nurse explained, PPE should be worn in every delivery. However, the staff's routinized practices were discordant with these guidelines. And, kind of going into labor, they knew who was positive and who was not. And that was what actually directed the use of PPE. So now it's your turn, and I want to use again the chat function to share some wisdom and your reflections and reactions to this uh, case scenario. So the woman who I started with, whose scenario where she experienced the gown, gloves, and mask, why do you think she experienced that as stigmatizing? Why do you think PPE might be applied differently for women living with HIV, and or hepatitis, even though the guidelines say PPE should be worn for all deliveries? And could this be handled differently? Is there something that you might do or say in this scenario? So I'll just give you a minute to react and to jot down some of your ideas and thoughts and suggestions. So in terms of why you think PPE might be applied differently for women living with HIV, Jennifer indicated fear, and absolutely, that was, you know, something that the people that I talked to were very honest and open about. There is a lingering fear, even if, the evidence might say differently. Paranoia. Yeah, so Joanne has indicated that there are so many pics online of natural childbirth with unmasked and ungowned attendants. Absolutely. And this woman in particular, this wasn't her first experience of childbirth. She had older children as well. So, her previous experiences were not like this at all. And so it was a, stark difference from what she was used to. And Nevleen also says, I think the MD's demeanor prior to the delivery regarding her HIV status had more of a negative impact than the act of wearing PPE itself. So it set up this, encounter, this relationship that just kind of exacerbated when he came back into the room with the PPE. Yeah, I would definitely agree with that based on my experience with this woman. So Kate has suggested to include information about what the delivery environment will look like during prenatal visits and normalize that staff wear PPE for all deliveries. Yes, and I think I had even heard about, maybe a woman could have a tour of the labor and delivery area, in advance of coming, if that's possible, or at least be given a little bit more detailed information about what to expect. So we do have, yeah, so possibly some information might be needed around undetectability, and also thinking about our biases around perceived risk of exposure. I agree, Carly, that every case should be treated routinely, routine precautions, and notifying mother. This is routine practice for all deliveries. But I think what's interesting is this creeping in of that there was differential treatment. So, this labor and delivery nurse that I was speaking with was saying that even though the guidelines do treat PPE as routine for all deliveries, there was they were a bit more lax when they knew that the serology was negative. So, in terms of how the guidelines are written, but then implemented, there was a disconnect there that I think is really important to acknowledge. So, agree, Angela, could be a role for peer mothering support and guidance. And yeah, the nurse educator or the clinical leader that's affiliated with this team, it would be really great to kind of revisit some of the IPAC practices and differential treatment of different women. Yeah. So even though there's this policy in place, is it actually being implemented as it should be? Awesome, everybody. Thank you so much. So I just have a couple more minutes left, and I want to make sure we have a bit of time if there's any questions. So I think it's really important to recognize that all of the things that we've been discussing are occurring in a socio-historical context. Despite the advances that have been made as it relates to HIV treatment, there hasn't been really a systematic unlearning of the historical understandings and assumptions about HIV and AIDS. And when HIV first emerged, there was a healthy dose of fear that permeated the media and other kind of forms of in discourse. And healthcare literature dating back to the 80s and 90s has reified this fear of contagion and this idea of fear of possibly acquiring HIV and brought it into the healthcare sphere. And as these headings depict, nurses and healthcare professionals are concerned about their level of risk and in history have refused to care for people living with HIV. And I would argue that this discourse of HIV as contagion and risk lingers today, and it can work to organize people's work in healthcare. And that one nurse did say to me, for people who have been in healthcare or nursing a lot longer, there's still that little bit of fear that never went away. So just want to say that, as I mentioned at the very beginning, women living with HIV are typically connected to their HIV and maternity care specialists. Although they're encouraged to be seen in a high risk setting, women themselves know what steps they can take to reduce the chance of HIV transmission to their baby. And they actually question the extent to which they are a risk to their baby, given the fact that they're on treatment, they have undetectable viral loads, and they're doing everything that they're being recommended to do. So in terms of the work that I've been a part of, it's really thinking about working with women as a source of support and not an additional source of surveillance, and really kind of talking with women, making sure that information is being relayed in clear and accessible ways, supporting them if they need access to other programs or services, and working collaboratively with the other providers that they might be seeing. And also thinking about how your work is connected to kind of like other and more broader structural and systemic issues that we still see. So, ask critical questions about how the women you work with may be affected by various forms of oppression, in addition to HIV stigma. Think about how your work connects to, structural calls to change how our systems are organized. So, for example, the Truth and Reconciliation calls to action and grounding your work in an anti-oppressive practice framework. It's really thinking about how the routine practices, the things that we do day to day, the policies that we use. Um, it could be prenatal care guidelines, it could be care standards, infection control practices, risk management policies. How are these things maybe reinforcing social inequalities or resulting in this idea of differential treatment of different women, as Jennifer said in her comment? And I think what I've shared today is specific to women living with HIV in, kind of the obstetrical world, but I believe that it can transcend to other areas of healthcare and other groups of service users, people on the receiving end of care. So I just want to make a plug for this toolkit that myself and a large group of people have been working on. It's available to enhance the work of people providing care to mothers living with HIV. It's available online through Katie, and also hard copies can be ordered in Ontario. And if you don't live in Ontario, you can email me, and I'm sure I can send you some copies. I've included the link here in this slide of how to download it online, as well as some additional resources that you might find helpful. And I just want to say thanks very much for everyone's attention. Please email me if you have additional questions after today. And I guess we can just open it up for questions if there's any pointed questions from the presentation. So thank you very much, everyone.
Thanks so much, Allison, for that very informative presentation and for highlighting some of the challenges faced by women living with HIV when accessing perinatal care. So as Allison said, please use the chat function with any questions. I'll read them aloud and then hand it over to Allison. I see there's one question from Grace. Will this presentation be sent via email to the participants? Yes, so I will be sending a thank you email to all of you on the line today in the next few days, and we'll include the link to the presentation as well.
The book is called Supporting Mothers in Ways That Work. I can show it to you again here. Yeah. And that resource is specific to mothers living with HIV. So basically, this resource synthesized a bunch of we did a series of qualitative analyses from all of the interviews that we did with mums across Ontario, and synthesized it into this toolkit that is organized into chapters. So there's a chapter just on infant feeding, there's a chapter on criminalization, there's a chapter on stigma. So yeah, it is specific to mothers living with HIV, and we have done some work with Angela Kaida, who's on the line, to bring some of this information out to BC. We also took the information out to Saskatchewan, and we heard that women in other provinces resonated with a lot of the things that we were learning from mothers in Ontario. So we do see this as applicable kind of in all jurisdictions. So we invite you to download the PDF or email me if you would like hard copies and don't live in Ontario. If you are in Ontario, it is also available through the Y Strategy, the Women HIV/AIDS Initiative. They have copies available through their website, and that is on this additional resources, this last link. Yep, so Janet, there you go. It's the last link there. And they actually have a bunch of other really great resources. They just put out a disclosure toolkit as well. And as Renee mentioned, we're also, through the Canadian Aboriginal AIDS Network, there's work underway to develop an Indigenous version of this Supporting Mothers in Ways That Work toolkit. So, and I think it's called Stories from the Cradle Board, or something to that effect. So that is also in development at the moment. And if you have kind of bigger questions, or if you want to chat further about this work, happy to email with people. My email is on the last slide here if you want to jot it down. I really appreciate your feedback and comments or questions as I work to complete my doctoral research. Would really appreciate your comments. So thank you everyone again for your attention, and yeah, it's great. Thanks, Angela.
All right, so
Thank
thanks
you,
again,
everybody.
Allison. Sounds like a lot of people are saying thank you. We'll just wait and see if there are any further questions. But in the meantime, as I mentioned, this webinar is being presented as part of a webinar series, all focused on how we can reduce stigma related to sexually transmitted and bloodborne infections. And so if you want to learn more about that webinar series, you can access some more information on CPHA's website at the link provided on the screen. And then lastly, I will ask all of you to take a few minutes just to complete our webinar evaluation survey. This just will really help us improve future webinars and make sure that we're getting great information out to all of you. And then, as I mentioned, the webinar was recorded and we'll be posting it on CPHA's YouTube channel in the coming weeks. And you can also access some of CPHA's resources related to STDs and stigma reduction on our website, or you can contact me directly, Rachel McLean, at the email address provided there. So with that, I think we'll close the session. Thanks again to Allison and to all of you for participating. It was a very informative and engaging presentation. Have a great day, everyone.